Good afternoon and welcome to our critical care megacode demonstration video. We are here to demonstrate to you the components for megacode, and I'm here with myself, Professor McDonald.
I'm Professor Balalovich.
We have two students, Caitlin and Lindsay, and Ms. Blackwell here to go over this with you.
I'm Instructor Blackwell, and this is taking place in the STAR Center. When you come to the STAR Center to practice for megacode, you want to make sure that you follow through on coming during the time that your instructor will have scheduled for you. When you come into the clinical setting here in the STAR Center, you're going to find that the bed may be up, down, and so I want to just show you how to use and utilize the equipment. So on the bed rail here, you can raise and lower the bed. You want to make sure when you're doing CPR that it is comfortable as you're doing that the bed isn't too high or too low. You can also on the inside here raise and lower the head of the bed. Then with the bed rail itself, also so that you're comfortable and being able to effectively do your CPR, just simply press the button on the side of the bed rail and lower it down. All right, let me give you the scenario of what we're working with today in this traumatization. We have a 62-year-old female who has been admitted to the hospital for fever and chills, and she's had that for the last 2 days. She has had an influenza swab and is awaiting results. She is awake but drowsy.
All right, so the first thing I want to do is assess my patient. You said she was awake and drowsy, and she does have a pulse. Can you confirm that she has a pulse? I see on the monitor that her heart rate is 45, which is bradycardia. She's symptomatic bradycardia as her pulse rate, or as her blood pressure is low. So I need to do some supportive care. If we could put her on 2 nasal cannula, also establish an IV and have some fluids running. With bradycardia, one of the medications I can use is atropine, 0.5 milligrams IV. I can do this 6 times for a maximum of 3 milligrams. So after the IV is established, I'd like to do the atropine. If we could have that ready, please.
All right, IV's in.
Thank you. And that is atropine, 0.5 milligrams, IV push. We're going to do this every 3 minutes.
Patient is still very drowsy and not responsive.
Okay. We've given her atropine.
Atropine is in,
Okay,
followed by flush.
thank you. And I see on the monitor there's no changes. Blood pressure is still low. We can use medication. Another medication we can use is a dopamine drip. We can do 2 to 20 micrograms per kilogram per minute, so we can get that infusing. And that'll help with the bradycardia and the low blood pressure, keeping the oxygen on her as well.
Dopamine is infusing at 2 mics per kilogram per minute.
And
There's no change in the monitor and the patient remains drowsy and slow to respond to verbal stimuli.
okay, so now we need to consider transcutaneous pacing. So if we could put the patches on her, please. We're going to set the machine to pacing. We're going to start at 50 milliamps, and then we'll increase until we see capture on the monitor, and that'll be evident by a pacer spike.
Pacer is on. Pacer has defaulted to a heart rate of 70 and an MA of 50. IC capture.
All right, sir. And do we have a perfusing pulse?
She still has a pulse at this
She
time.
has a pulse.
Okay. So at this time we could leave the dopamine running. She has a pulse. And then we would continue to monitor her. Monitor for any changes that could happen. Making sure oxygen stays on her. And looking at the monitor, it looks like we have a rhythm change. We are now in a tachycardia, a supraventricular tachycardia, so I'd like to turn the pacing off at this time.
Pacer is off.
I'd like to check for a pulse.
It has a pulse.
Okay, and what I'd like to do now is if we could ask the patient to bear down, see if we could slow her heart rate down, a vagal maneuver. Is that successful?
It's not successful.
Okay, so what we need to do now is consider adenosine. So we can do adenosine 6 milligrams IV push, followed by a rapid saline bolus.
Adenosine 6 milligrams in, followed by a 20 cc flush.
And the
There's a
patient,
slight little pause, and then the rhythm continued on as it was after getting that adenosine.
okay, so there's been no change in the rhythm. Is the patient still has a pulse?
She has a pulse, very weak pulse, yes.
What I'd like to do is repeat the adenosine and do adenosine 12 milligrams this time, IV push, followed by a rapid saline bolus.
12 milligrams adenosine
There was a little pause after the
In.
adenosine, and
followed by a 20 cc flush.
but she's still right back up to that rapid rate.
So at this point, the adenosine did not work, so I'd like to do synchronized cardioversion. If we could change the machine to synchronized cardioversion and deliver a shock.
How many joules?
100 joules, please.
100 joules. Ready to shock, all clear.
I'm clear,
Everyone
you're clear, we're all clear.
Shock delivered.
Shock delivered. Has there been any change in the patient?
Patient has now had a rhythm change.
Do we have a pulse?
No pulse.
We need to begin CPR. If we could get the backboard, if you could get the back valve mask, please. Patient's in ventricular fibrillation. We're going to start CPR at a rate of 30 compressions to 2 ventilations. We need to make sure our compressions go 2 inches down in depth and allow for recoil.
12, 13, 14, 15, 16, 17, 18, 19,
If we could get
21, 22, 23, 24, 25, 26,
If we could get the
27,
machine
28, 29,
to
30.
defibrillate, please. We're going to defibrillate at 200
Charging,
joules.
200. All clear.
I'm clear, you're clear, we're all clear.
Everyone clear? Charge delivered.
So resume
1,
CPR.
2, 3, 4, 5, 6, 7, 8, 9, 10, 11,
No
12,
change in
13,
rhythm.
14,
No
15,
pulse.
16,
Ventricular
17,
fibrillation, we can go to
18,
medication. We're going to do
20,
epinephrine 1
23,
milligram.
24, 25, 26, 27, 28, 29,
Epi
30.
1 milligram.
We can give this medication every 3 to 5 minutes with no maximum.
1, 2, 3, 4, 5, 6, 7,
Epi
8,
delivered
9, 10, 11,
with a
12,
flush.
13, 14, 15, 16,
So at the end of our 5
17,
cycles or 2 minutes, we're going to do a pulse check. So let's hold CPR and check for a pulse, please. Do we have a pulse?
No pulse.
Resume CPR. We're going to do another shock at 200 joules. If we could set the machine to 200 joules, please.
Charging. 200. All clear.
I'm clear, you're clear, we're all clear.
Shock delivered.
Resume CPR.
1, 2, 3, 4, 5, 6.
I'd like to do amiodarone
10, 11,
300 milligrams for my next bolus,
14,
please.
16, 17, 18, 19, 20, 21, 22, 23, 26.
Patient
still doesn't have a pulse.
30.
We're going to do CPR for 2 cycles or 5 minutes. Amiodarone 300
Amiodarone
milligrams.
300 delivering.
5, 6, 7, 8, 10, 11, 12, 13.
Followed by a flush.
15,
Amiodarone
16,
in.
17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29,
Okay,
30.
we're going to hold for a pulse check, please. Do we have a pulse?
No pulse, but there is a rhythm change.
There's a sinus rhythm on the monitor without a pulse. This is PEA, pulseless electrical activity. Resume CPR.
1, 2, 3, 4.
We're going to do epinephrine 1 milligram, IV every 3 to 5 minutes. This is the only medication that we could use.
18, 19, 20, 21, 22, 23, 24, 25.
Some of the reasons for PEA include hypovolemia, hypothermia, hypoglycemia, hyperhypokalemia, as well as hypoxia, cardiac tamponade, tension pneumothorax, toxins, or thrombosis, either cardiac or pulmonary. It is
Epi in.
Thank you. It's likely this patient has hypovolemia. We are at a pulse check stop, so we could stop and check for a pulse. Do we have a pulse?
She does have a pulse.
Okay, we have return of spontaneous circulations. We no longer need CPR. We can continue the fluids going because she's most likely hypovolemia. We are going to do our ROSC protocols. We would like to get a chest x-ray and an EKG. And have her arranged to go to the ICU. And hypothermia protocol per the hospital's protocol.
Great job, everybody.
Thank you. And that is the end of our demo.